Good afternoon. Thank you, everybody, to joining this preceptorship program. And I'm really thankful to Oncology Club for inviting me for this occasion. My topic is PSA screening and its role in diagnosis. And as you know all, there's a controversial issue, and prostate cancer is very common and is among young men and causes cancer-related death. However, at the same time, in many cases, prostate cancer grows slowly and that it does not impact survival. A routine screening is controversial. In 1853, John Adams, a surgeon at London Hospital, described the first case of prostate cancer, a very rare disease. However, 150 years later, prostate cancer has become a significant health problem. Dramatic increase in the number of prostate cancer has several reasons. First, prostate cancer was not differentiated from the other type of urinary obstruction until 1990s, 1900s. And second, the incidence of prostate cancer increases more rapidly with age. We are having now aging population. So age is one of the factors for increasing number of prostate cancer. And third is the Western lifestyle. Since 1980s, we are getting more diagnoses because small and localized and well-differentiated prostate cancer is increasing. This is due to two reasons. One is prostate-specific antigen, and another is availability of needle biopsy with multi-core schemes of prostate biopsy. Now the prostate cancer is the most common non-keratinous and second leading cause of death from cancer in the United States. However, the treatment option of prostate cancer remains interesting and controversial. So there is a saying by Lyman Beecher that no great advance has been made in the science, politics, or religion without controversy. Even not only the controversy, the prostate cancer screening is like a swinging pendulum from one end to other. We will be discussing more in the following few minutes. If you look at the incidence of mortality of the prostate cancer, and incidence is always high, even if you see the autopsy report, but the mortality rate of prostate cancer remains low in the whole, in spite of high incidence. However, it is the second leading cause of death in male cancer. So screening is being done for about the last 30 years. And as you know, the screening is the presumptive identification of unrecognized disease or defect by means of test, examinations, or other procedure that can be applied rapidly. So main goal of cancer screening is to reduce the number of people who develop the disease, reduce the number of the people who die from the disease, or prevent the death from cancer altogether. So there are 10 criteria of effective screening. The disease has serious consequence. Screening population of high prevalence or detectable preclinical phase. Screening test detects little pseudo disease or overdiagnosis. Screening test is affordable and available. Screening test has high accuracy in detecting the detectable preclinical phase. Screening detects disease before the critical point. Screening test causes little morbidity. Treatment of the screened disease exists. Treatment is more effective when applied before symptom begins. Treatment is not too risky or toxic. You can see that not all criteria of screening is actually fit for prostate cancer. There are some controversy with some of the points. And we have prostate blood test for screening. And also says about digital rectal examination for clinical examination. So why prostate cancer being under screening in 1990s? At that time, there was high incidence and prevalence of the disease in the society, poor outcome of the metastatic prostate cancer. Screening tools, PSA, became easily available and affordable, and PSA detected tumor were often cured with radiation or surgery. But the prostate cancer screening by PSA remains controversial. However, the Catalona, the eminent, eminent urologist in United States, he started screening in around 1991, and he says he published his first paper on screening, and at that time he says the early diagnosis of prostate cancer through PSA testing saves life. That was followed by relative adaptation of PSA screen in North America and Europe. So that was actually in 1990s. At that time, early approach to the prostate cancer screening and treatment was like this. Population at risk, all men greater than 50 years. PSA test annually greater than 4 nanogram per ml. Biopsy all men. If the patient has cancer, treat all cancer. And if there is no cancer, then leave the man alone. So there the controversy starts. Screening to be valuable, it must reduce the disease-specific morbidity and mortality by detecting the cancer at early stage. However, detection at early stage does not necessarily correlate with clinically beneficial outcome. Increased detection of the prostate cancer subjects some patients to risks associated with treatment that may not prolong life. They may have, and that have risks of morbidity. You can see here is the graph where you can see the prostate cancer incidence, and it increases suddenly in around 90s, and then reached at the peak where the test was available. More and more men was actually were coming for the test, and there is a gradual decline in the incidence at the same level that was started previously. So there is a peak because of the multiple test was done by the people, but not. But so the prostate cancer screenings don't have any real effect of reducing incidence of the prostate cancer. Declining mortality. That's a controversial talk. Whether it is due to screening, improvement of treatment for but there are some improvement in the treatment of localized and metastatic disease. As you know, actually some of the country, they do not actually adopt a screening program, but the mortality of prostate can also decrease in that country. So you cannot really say solely that was due to due to screening process. So risks of prostate biopsy. Men with abnormal result of screening may have prostate biopsy to determine if the prostate cancer is present. The complication of prostate biopsy includes infection, pain, bleeding, urinary obstruction, etc. Up to 2% of the men can have these complications. And there is another possibility of overdiagnosis, detection by screening of a condition that would not have become clinically significant in the patient's lifetime. This is overdiagnosis. And studies show that increased frequency of diagnosis of prostate cancer, particularly low grade, but no survival differences between the screening and non-screening group. Diagnosis with the prostate cancer increases from 1 in 11 to 1 in 6. The lifetime risk of dying from prostate cancer remains same in around 1 in 34. The computer simulation model to study from the CRs and ERs SP estimated that 23 to 50% of the prostate cancer diagnoses were likely to be overdiagnosed. The risk of overdiagnosis of prostate cancer appears to be increasing with increased age. There is a chance of false positivity as well. Patients may have anxiety for the test, as well as false positive rate depends on the part. Actually, the more the PSA level, and more is the chances of false positivity. And anxiety is also a factor, because the patients with or without a diagnosis of biopsy, if the negative biopsy can even the negative biopsy can also cause anxiety of the patients, which is very difficult to eradicate. Risk of prostate cancer therapy. This is also a problem because you know that radical prostatectomy and radiotherapy also have complications like urinary symptoms, incontinence, impotence, and bowel dysfunctions. So are we doing unnecessary overtreatment? Finding of an elevated PSA often lead to biopsy with attendant risk of complications followed by unnecessary overtreatment. The potential resulted in more lasting complications like sexual dysfunction and urinary incontinence. So this leads to frustration to the patients, to the public, as well as even the Richard Elvin, who is the discoverer of PSA, and he wrote an article in New York Times in 2010, and he said that that was a great mistake to identify, so to discover the PSA. So he said that screening man with the prostate cancer with the man with prostate cancer has become a hugely public health disaster. This controversy provokes understanding the natural history of the disease and to conduct the clinical studies like RCTs like ERSPC, European Randomized Screening for Prostate Cancer. And in the United States, there's another study called prostate, lung, colorectal, and ovarian cancer, and pivot studies. So if you want to see the natural history of the prostate cancer is a heterogeneous disease. Prostate cancer arises from genetically altered epithelium, and the course of the prostate cancer is difficult to predict. Many men not experience any symptom of prostate cancer in their lifetime. If you look at the natural history, 30% of the men in their 50s and 70% of men in their 70s can have prostate cancer. Prostate cancer is diagnosed only 12% during the lifetime, 3% risk of cancer death. And 5 years survival rate almost in most men with local and regional prostate cancer is nearly 100%. Metastatic prostate cancer, the 5-year survival rate is 13%. Only 16% of diagnostic prostate cancer until they die of it. So we can see from this picture that before it is clinically evident, the prostate cancer may remain subclinical for over 10 years. So it's a long process to develop a clinical disease, and before that patient may die for other reasons. So this also lead to other researchers like Epstein. He also analyzes the prostate biopsy reports, and he described some criteria of prostate cancer like Gleason 6 and below as an insignificant disease. And also another study conducted by D'Amico, and he said that there are presence of low risk, intermediate risk, and high risk disease. And for low risk disease, he says there's very little chance to be metastasized and doing harm to the patients. Another study is that they followed conservatively about 20 years for localized prostate cancer. They says that the chance of prostate cancer mortality increases with increasing Gleason score. So the RCT subsequently come up from the Europe as well as from the USA. And this ERSPC trial, they recruited about 182,000 men and examined the role of PSA screening largely in unscreened population from 8 countries. And after 13 years of follow-up, they found 21% reduction in death from prostate cancer. This reduction in the risk of death is found to be predefined subgroup around 55 to 69 years. But in the PLCO trial, they recruited about 76,000 men. And after 13 years of follow-up, there was no evidence of a mortality benefit for organized annual PSA screening and compared with the opportunity screen used in normal care. So based on these two studies, United and the public opinion and the morbidity and mortality, consider mortality of the patients undergone screening, the United States Preventive Task Force actually made a controversial decision. And they said that moderate and high certainty that service has no benefit or that harms outweigh the outweighed the benefit. So they assigned D to the PSA-based screening for prostate cancer, and mainly meaning that they recommended against the prostate current practice. After these guidelines are published, PSA screening remained controversial, and individual screening practice have continued, although very varied way. So other organizations in around the world, they have also made some decision out against the screening, like Canadian Task Force on Preventive Health, American College of Preventive Health, American Academy for Family Physician, but American Urological Association implemented that shared decision making for men 55 to 69 years of age and proceed on the basis of men's value and preference. There are some differences in the society guidelines, but the US Preventive Task Force and other task forces, they have actually recommended against the screening. And the urologist, again, the Catalona, he said that opponent of screening who suggests that men should not seek early prostate cancer diagnosis are doing disservice to the public. So controversy is going on. So the researchers come out with analysis of PLCO and ERSPC trial, and if you can actually analyze the PLCO trial, that shows that the control group of PLCO trial appears to have actually undergone equal or more intense PSA screen than the assigned PSA testing. So the study has some flaws, and actually they have some. They are not really representative of the actual picture. In contrast, the European study on prostate cancer, they said that there was 20% reduction in the prostate cancer mortality, but the reason for actually excluding this study as well, that it takes around 1,400 patients needed to be screened to prevent one prostate cancer death. The most recent update from the ERSPC estimated that only 570 men from 55 to 69 years of age would be needed to be screened to prevent the one death from prostate cancer with 16 years of follow-up. So the original actually exclusion was due to 1 in 1,400 patients, but the subsequent study shows that less men need to be screened to get a good outcome. So again, if you can see the mortality graph after this stopping of widespread screening, that is trying to be gradually increasing, and you can see there are some literature published afterwards after stopping the screening process, and it was actually increasing. And if you look at the breast cancer screening, that in breast cancer screenings, we need to screen 1,250 women from 50 to 59 years of age, and 470 women from 60 to 69 years of age to prevent one death from breast cancer screening. So it is quite similar with the prostate cancer. So why we should exclude prostate cancer from the screening process? So US Preventive Task Force come up with final recommendation of that the population man is 55 to 69 should be screened, and decision they actually upgraded their recommendation to grade C, so that informed decision should be taken, and particular age group like 55 to 69 and some particular patients like older age, like African American family history of prostate cancer can have some screening process. So now the altered approach is the shared decision making and risk adjusted approach. So in the shared decision making, the patient needs to inform all the problems can come with the prostate cancer, the need for biopsy, again, there are need for additional tests like MRI, what are the complication of biopsy and what is the complication of treatment. And knowing all these, patient should decide whether he want to go for biopsy or not. And in average population, they recommended the prostate cancer at age of 50 years of average risk, as long as life expectancy is 10 years, at least 10 years. And if the patient is a BRCA carrier, they recommended to begin the screening process as early as 40. And other high risk men like black man and family history of prostate cancer, particularly first degree relative who diagnosed at the age of less than 65, should go earlier screening process. What are the tools for screening? Normally, still PSA and digital examination, but the digital rectal examination by family physician is a controversial issue nowadays because their specificity sensitivity is much lower than and the positive predictive value is 41%. Other tests are not recommended for screening tools. And we know that we started to evaluate prostate cancer if the prostate cancer PSA is greater than 4. However, there is no single PSA value that avoids missing important cancer or at curable stage, avoid false positivity and detection of clinical inseminate disease. If the patient is taking finasteride or dutasteride, correction must be applied to a PSA result for accurate interpretations. And as you know, ARI are known to lower the PSA results. Age-specific PSA we need to look for as well. And race-specific PSA, there are certain Black people, they need to screen at a particular lower level, start screening at a lower level. And even the PSA can vary in the monthly or daily basis. And there is seasonal variation of PSA level as well. These are, but they don't have any very large clinical implications. In the PCPT trial, we see that less than 4 nanogram of PSA can have 15% of the cancer. And if the PSA is greater than 10, then PSA cancer can be present in 67% of the cases. So how frequent we can test the PSA annually or biannually? There are a lot of discussion on it, but serial PSA is more important than once only PSA. You can defer temporarily the PSA testing if there is a symptoms of urinary tract infection, acute detention of urine, prostate biopsy, perineal trauma, etc. And discontinuation of screening, then if the patient's life expectancy is limited or less than 10 years, and if the patient reaches at the age of 70, or some of the guidelines said that you can even go up to 75 years of age. So conclusion, the best available evidence from the randomized trial found that screening has at most a small benefit in reducing the prostate cancer mortality and risk of developing metastatic disease. The potential benefit of screening must be balanced against the potential harm to the quality of life, including the risks of false positive test, prostate biopsy, anxiety, overdiagnosis, and treatment for complications. For average risk mass, many clinicians do not specifically advise in favor of or against of screening. Men who are candidates for screening should be engaged shared decision making about whether they choose to be screened. Men who are being screened for prostate cancer should have life expectancy at least 10 years, race, age, and family history to identify whether man is at a higher or average risk for prostate cancer. Thank you for this patient sharing.